Good morning, everyone. We're on the top of the hour, 12 o'clock. We're just waiting for our presenter, who is Dr. Todd Vento, the Medical Director of Telehealth Infectious Diseases at Intermountain Healthcare and Connect Pro. By the way, beside me is Sue Lee.
Hi, I'm Sue. I'll be the student representative for this meeting.
Yeah, Sue Lee is a second year?
First year
medical student. And today is December 1, by the way. And do you know the significance of December 1?
It's World AIDS Day. It's World AIDS Day.
Yeah, it's World AIDS Day. That's correct. And this is we're doing this webinar in celebration of the World AIDS Day. Do we have Dr. Vento on the line already, or not yet? Well, anyway, while waiting for Dr. Vento to sign in, today is World AIDS Day, and the theme of the celebration is Rock the Ribbon. This is to stop the new HIV cases. I don't know if you knew, Lee, but up to now, HIV is still, a problem, not just here in the United States, but globally. And we're also wanting to prevent new cases of HIV, at the same time securing the rights of people living with HIV and fighting the HIV stigma and discrimination. Probably we could go in while waiting for Dr. Bento to do our, housekeeping.
Okay, just some statement like this educational activity, this project of TexLa Telehealth Resource Center, a federally funded program with Murray Hall Rural and Community Health at TRC, as well ahead Louisiana, with generous support from Health Resources and Services Administration.
All right. Well, Dr. Bento apparently is just finishing up a clinic, but while he's finishing up the clinic, I would like to take this opportunity to thank Dr. Shermer, because we're doing this webinar in conjunction with the internal medicine grand rounds. And while waiting for Dr. Bento, I will just introduce him. Dr. Vento is the medical director of Telehealth Infectious Disease and Intermountain Connect Specialty Care at Intermountain Healthcare. He oversees the delivery. Yes, next slide. He oversees the delivery of ID telehealth care for over 30 healthcare facilities and supports telespecialty care program delivery across 10 states in Intermountain West region. So he's covering 30 healthcare facilities. We could advance the slide, please. He has extensive experience in clinical, operational, and academic medicine, serving in leadership roles from clinic chief to hospital chief of the medical staff. Next slide, please. That is just the helpful tips, by the way, to all the attendees. Dr. Vento receives his medical degree from Uniform Health Services of the Health Sciences, USUHS, and MPH in Epidemiology from the prestigious Johns Hopkins University School of Public Health. He completed internal medicine and preventive medicine and public health residencies and infectious disease fellowship. He is a fellow of the American College of Physicians and Infectious Diseases Society of America and holds International Society of Travel Medicine certification. He is the chair of Infectious Disease Society of America, also known as IDSA, Mentorships Committee, and member of IDSA's Telehealth and Emerging Technologies Committee. Dr. Vento has published on a variety of public health, telehealth, and infectious diseases topics and holds an academic appointment at USUHS, the University of Texas Health Sciences Center, San Antonio, and University of Utah School of Medicine. Is Dr. Vento with us right now?
Still not available yet.
Okay. Well, by the way, if you guys have any questions, kindly put in your chat box.
Your name and your email in the chat box, and any comments and questions. Make sure you fill out the session evaluation to obtain those CME credits.
All right. Well, while we're waiting for Dr. Vento to come in, typically in infectious diseases, Sue, we don't use telemedicine because people want to make sure they are tested. They make sure that the they could evaluate and examine the patients, right? You will not just give antibiotics unless you have indication for the antibiotics. However, there are several indications of using telemedicine. I'm not quite sure if you're aware, but in the treatment, for example, of tuberculosis, there is what we call directly observed therapy, and in not just here in the United States, but especially in Africa and Asia, where tuberculosis is predominant or still number one killer. What they do is use telemedicine to directly observe the patient taking their own medication. Yep. And so they found that using directly observed therapy, or EDOT, essentially the telehealth version of directly observed therapy, they said that compliance to medication and treatment is much better. Is Dr. Vento here already? You'll just keep on checking.
We got word that he's trying to get on. It's just computer issues. As always, you try to jump on, and that's the best time to update, right?
Yes. While we're waiting for Dr. Vento as well, today is HIV Awareness Day, right? And it's a World AIDS Day. And one of the medication that's proven to be helpful is the PrEP drug. Are you familiar with the PrEP drug?
Not yet.
Not yet, but you will be eventually. And there are a lot of ways of, prescribing medications and probably even securing medication for patients with HIV or at risk on HIV, so we could prevent and decrease the risk of people who are, at most risk for HIV.
Do it is it only like a prophylaxis or like?
Yeah, the PrEP is prophylaxis.
Oh,
yeah.
okay.
However, you mentioned treatment of patient with HIV. We actually have an HIV clinic here at TTHSC, and we manage people in Abilene area, who have HIV. And our infectious diseases, experts and specialists take care of their, needs, make sure their medications are in compliance, make sure you're taking their medication. And at the same time, I think, it's not just infectious diseases. We want to make sure that there's no drug-to-drug interaction.
Mhm.
So this is a good way as well that our pharmacists, could look into the medications and making sure that there's no drug-to-drug interaction.
Do they use in fact, do they use the online program for the HIVs?
Yes,
Oh.
and some of the prescription as well for the medications could be given online as well, or via virtual ways. So you could get your prescription, virtually to your, nearest pharmacy, or the pharmacy could deliver it to you.
Okay, that's nice.
Yeah. While we're waiting for Dr. Vento, I would just like to share as well, the position paper, and Dan Stewart, our librarian. I would like to acknowledge, by the way, Dan Stewart, who is our resident librarian, who will give you references as well to all our, references in this talk. One of the position paper that I would like to share is the position paper of the Infectious Disease Society of America. They actually embrace telemedicine, and I think there are really a good indication for telemedicine or telehealth when it comes to infectious diseases. And one of them are remote patient monitoring. The other one is what we called OPAT, or outpatient parenteral antimicrobial therapy. As a surgeon, we have a lot of patients that we prescribe, medication on, and they could go home their medication, and we could, follow them up using the OPAT. Anyway, I think Dr. Vento is here with us right now. Dr. Vento, good afternoon here at Texas.
Well, thank you so much. First off, my most sincere apologies. And I think we know what one of the first challenges we should discuss on Tele is getting the time zones aligned and sync. And I have to apologize to Laura. I had been asking, and I got to say, I made the assumption of folks being in El Paso, which I think was where I made the mistake. So I am so sorry about that.
No worries. El Paso is still, are part of our system. They are autonomous, but they are part of the Texas Tech system. By the way, I already introduced you, Dr. Vento. Dr. Vento is the medical director again of the Telehealth Infectious Diseases of Intermountain Healthcare and Connect Pro. And we chatted a little bit about World AIDS Day and OPAT and directly observed therapy. So
I heard, and
yes.
I wish I would have actually been part of that discussion. It sounded very good.
You're the expert, sir.
Well, let me get rolling here so we don't, and I can keep us on time, and I'll just switch out my slides if that's okay and take over sharing.
Yes, sir. Go for
Let me
it.
get this right there. Okay, hopefully you can see. Let's get your slides. There we go, so I can see everybody. Okie dokie. All right. Well, again, my apologies, but I hope you can see the title slide with a mountain and the picture of the hospital. Is that showing up?
Yes.
It's beautiful, sir.
Okay. Well, that's I always joke and say that's our obligatory picture so that people are like, really? Is it really like that? And I'm thinking, the mountains seem a little embellished in that photo, but maybe that was the recruiting section of Intermountain put that slide together, or put that picture together, I think. I don't know. But it is often somewhat like that in the mountains. So if you're ever out this way, bring your skis. Okay. Well, I was asked, I think last or in the summer sometime to share some of our experience, but also given that this is an echo format, I believe, and trying to sort of put into a case. So I decided I'll put in to demonstrate some of the examples of tele, which and by no means do we think that we're the only ones doing this, because so many people have had such great success, especially if you have a Office of Rural Health, and you understand that I gave some talks at ID Week over the year, Infectious Disease Society's annual conference over the years, and what I noticed, and have sat on some committees and work groups, et cetera, and even when folks get together, a lot of us obviously were trained in academic medical centers in urban environments. That's just the nature of the beast. You don't get a subspecialty fellowship in a town of 3,000, right? It's usually in an urban center. And what I think happens still is that people do either research or evaluation of, say, stewardship or ID, looking at small community hospitals and rural hospitals, but you really have to go to them, or at least have an understanding, because the statement we always use is, you've seen one small community hospital or rural hospital, you've seen one small community hospital, because everyone is different. And I don't know if that's something, and by the way, I'm open to folks interrupting me, or if someone else wants to monitor the chat, and I'm happy to answer along the way and even leave time at the end as well. But I just want to emphasize the fact that what happens in a major medical center, an academic center, is really not the same in terms of the resources and logistics. And I was a former chief medical officer for a small community hospital in the Army, and I would always say it was the same 10 people, or STP, showing up at every meeting, like the same 10 people on risk management, the same 10 people on credentialing, et cetera, because you don't have other people. And so you have to really, I think, factor some of that into how you're going to provide care for folks by finding out exactly what their needs are. And I see there's something in the chat, but I don't, I'll let someone else just let me know what's in the chat. Okay, so I don't have anything to disclose in terms of financial or conflicts of interest or financial disclosures. And this is kind of a rough agenda. I do tend to like fishing metaphors when it comes to stewardship in particular, and tele stewardship. So pardon me for that. I don't fish a lot. So if I make stupid or erroneous fishing comments, certainly reel me in and correct me, I guess. But yeah, I'll just describe our overall structure so you guys have an appreciation of that. And then actually, let me make sure. Let me just make sure this one is showing up that I want. Yeah, here it comes. We'll talk about how we implemented the tele combined. It's an integrated, fully integrated infectious disease consultation plus stewardship together, and how we did that for our facilities and also for outreach sites, which we call our external, whereas our our intermountain sites are what we call internal. And we have 24 to 25 hospitals, depending on how you count, for Intermountain, but we also have outreach that we do across the entire Intermountain West region. And then we'll talk about some take-home messages on the successes and challenges, et cetera. Okay, so I'll just start with a case. I got a ID teleconsultation actually about 3 weeks ago when I was on the service. And they said, hey, I wanted you to go over this case. I got a patient with intra-abdominal and splenic abscesses. I need some infectious disease or antibiotic recommendations. And so just for presentation, 65-year-old male, had really unremarkable past medical history. Actually had presented with just acute onset, very severe abdominal pain, had lasted over 1 day. And on the second day, it was so severe that he had to go to the emergency department in his rural at a rural facility several miles from his house. He was diagnosed with a perforated gastric ulcer. And here's his chronology. So he basically ended up getting an exploratory laparoscopy initially and had repair. And then was doing okay, days 1, 2, 3, stayed on antibiotics, then had an intermittent fever. And then they actually did imaging and found out that he had really kind of a complicated, really 2 intra-abdominal abscesses that they put drainage catheters in. And I think we have a little bit more there. There we go. And then a couple of days later, he was discharged. At that time, I don't know that they recognized this, but there was also some small splenic abscesses or lesions that certainly could have been splenic abscesses. And when he was discharged, the discharging surgeon found out the next day and called us after the patient had been discharged and was doing very well. And the intra-abdominal cultures were strep viridans, which interesting was actually ceftriaxone resistant, which you don't see often. That's probably about maybe 5 to 8%, depending on which literature, and actinomyces. But so the question was, is he on the right antibiotics for what they saw? And my concern was, well, how did he end up getting the abscesses? And, it wasn't an embolic phenomenon, et cetera. So I'll just pause there and maybe ask, I'm trying to be a little echo-ish so that Dr. Aurora, I think, when I went and did my training, he always tell me like, oh, your telemedicine is not as good as echo because we do telementoring and you just do teleconsultation. And I'm like, au contraire, Dr. Aurora. We were mentoring all the time, but one case at a time and also on population stewardship. And we joked a lot about, echo versus telemedicine, which the answer is they're not mutually exclusive. We do an echo program as well. So the question is, anybody want thoughts or comments or concerns based on that presentation of a case? And maybe there'll be some echo learning specifically on a real clinical case.
By the way, Dr. Vento, we have the internal medicine group, because this is part of the internal medicine grand rounds in the big classroom there. So feel free to answer if you guys have any comments. Max is a facilitator over there at the internal medicine grand rounds room.
Awesome. Yeah. So this was actually from general surgery, but easily could have been a call from a hospitalist, because a lot of times the surgeons and the hospitalists will co-manage, and we often get the call from the hospitalist on our ortho or general surgery cases for antibiotic recommendations, even though it's primarily was a surgical patient. So,
Dr. Vento,
yes.
This is Dr. Chemitiganti from one of the regional campuses. Can you hear me?
I can hear you very well.
I'm glad you're starting off with a case. Can you just step back and give us, like, I hate the word, but the 10,000 square foot view of what your setup is and who are these people that are accessing you, and kind of whether these are synchronous visits, asynchronous visits, that kind of stuff?
Yeah, I'll go ahead and go into that, because that's really what the talk is about. But I had to be a little bit echo inclined, if you will, to was asked to put a case in there. So I'll just cut to the chase on this, because this really demonstrates it, and then I'll go right into that exactly like you asked about. So this gentleman, what I was concerned about is when he was febrile post-operatively is, was he having other cause of fever as well, aside from intra-abdominal abscesses, and why did he form splenic abscesses? So I actually asked them to get an outpatient echo, and they did, and he had a 1 centimeter tricuspid valve vegetation, endocarditis. It was interesting because he was actually on amoxicillin clavulanic acid, which wouldn't have been too bad, except he turned out he was actually resistant. His viridans was resistant. You don't see that a lot. This is mostly for maybe the ID nerds. But it was actually susceptible to clindamycin, and he had some, they had jockeyed his antibiotics around. So bottom line is we had to change the antibiotics, but find out what else he had. He ended up having endocarditis. And here's the tele and getting into the 10,000 square foot view. In a matter of 18 hours, I had our OPAT nurse, since you guys were talking about OPAT earlier, and our tele pharmacist that does home health tele, get him set up for IV antibiotics. And I had never seen this gentleman, but I got within the very next morning, I ended up getting a video visit with him while he was getting his PICC line at his rural facility.
That's awesome.
He actually got the echo at another facility about 30 minutes away that the surgeon coordinated. And then I saw him at the pick, saw the pick go in, and he and his wife walked to the car, and I continued my video visit while he was in the passenger seat. And when they got to their house, the home health folks had arrived with the antibiotics from a 45-minute drive away. And all that was coordinated by Tele in 18 minutes. And the gentleman got his first dose within, I'd say, 18 hours of us finding out what the echo was. So that's my big case-specific argument for Tele. Not that I have to sell Tele to you guys.
Dr.
This is
Bento,
actually-
before you proceed, I'm taking the the mantle for the general surgery because I'm a general surgeon. What kind of antibiotic was this patient given, while in house, and was the patient compliant, and or did they do the testing or the resistance, or do they do a culture, during the operation?
Yeah, so in the OR they didn't, but when they put the drainage catheter in for the abscesses that they identified postoperatively, so he had the gastric ulcer that was perforated, and then they closed it, and then he developed several days later some fevers and developed his intra-abdominal abscesses and the splenic abscesses pretty quickly actually. And so for the actinomyces, pretty much most of the things they had him on would have been covered. Even the ceftriaxone was fine. We ended up, I hope I can remember this, on the Viridins. I think we ended up going with daptomycin on him because of his resistance pattern. And then we left him on, I think, ceftriaxone for the actinomyces temporarily, but knowing that really once his intra-abdominal abscesses went away, we didn't feel that his endocarditis was caused by actinomyces. We thought that was just from his intra-abdominal abscess, and that the Viridins was probably the cause of his endocarditis. And so in the end, he finished off his intra-abdominal abscess treatment with the drainage catheter, all resolved. And then we got him on Justice therapy for the Viridins. And I believe we actually ended up having him on daptomycin instead of Vanc because he had some mild CKD. So yeah, for gram-positive coverage, and it's really unusual. And I didn't mean to sort of, linger on the ceftriaxone resistance part. But basically he went out on, I should let you know that he was on multiple different antibiotics over time during his hospitalization, including Vanc and Piptazo, sort of like the standard cocktail du jour, right? Vancomycin. But he left on Augmentin, but he wasn't being covered on his Viridins for the Augmentin, surprisingly, which is really unusual because Augmentin would have been a nice choice, amoxiclav. Typically, it just happened to be he was resistant. And again, sorry, that was not meant to be. Well, it just shows you that, look, there's a lot of things that happen in small community hospitals, which you can imagine this is not stuff that people will always have to see. So that's a benefit of having, 24/7 access to score line, we call it, or ID access. So let me jump ahead. And I think one of the benefits, just to show folks too, and this is sort of a little bit out of order, but I did want to comment that we do daily Tele ID ASP rounds, stewardship, antimicrobial stewardship rounds, to include our ID fellows, medicine residents, students, as well as pharmacy. And we do live case evaluation, and we'll even call the providers on the spot and say, hey, we're doing surveillance. And I like this because I bring this up right here because I want to emphasize the point that the clinician or physician doing ID has an important role beyond just their knowledge. It's also demonstrating to small community hospitals that we value the input of the ID pharmacist and that they can use them as a resource too. And I'll show you our setup that emphasize that. But this is John Villette. He's our telepharmacist. He and I started the program about 6 years ago and went to all these facilities and implemented 17 small community hospital stewardship programs. And we sit on their stewardship committees and help them from afar. And it's basically, teaching to fish and hanging around to make sure that they're still, fishing for salmon and not for sharks, things like that. And then, the beautiful part of this is like, people say, you can't do this, you can't do that. And I'm not trying to be the whole guy like, oh, people should do more tele and it's the best thing ever. I get that people have concerns. We've actually done studies on why people don't do video visits still. I will tell you that a lot of it is still, it's kind of like saying you don't like Brussels sprouts, but you never even tried them. And now I'm mixing metaphors for food and fish, but I have to highlight the fact that why is Samir smiling? Because he's from Saudi Arabia, and we were rounding the day that Argentina lost to Saudi Arabia, and they got a national day off, and we didn't know about it, and he was actually working on his national day off, and I'm like, well, you're in Utah, so But anyway, here's the 10,000 foot plus, in fact, satellite view imagery of electrical grids, right? And I don't have to sell this to you guys. I mean, let's see, you guys are over here somewhere, right?
Yes.
You see all this, right? Here's all that, what I call like academia, urban, lots of like cities and megalopolis, metropolis, etc. And you got basically like crickets out here, right? And so you can see the obvious benefit. I don't have to tell that to someone who does telehealth, but why telehealth?
Yeah.
Well, this is why telehealth, right?
Yeah.
So that's our area of coverage. We promise we're not trying to get anywhere near over here. I'll just let you know. Personally, I don't like the fact that this line goes all the way down here because it's getting harder and harder to staff. And no joke, they asked me to get my Hawaii license that I had when I was in the Army re-licensed, and they'll pay for it, which is always sounds, oh, that's nice. But then you think, wait a minute, what are we doing now? Something else. And what we did recently, we also we merged, and now we have the SCL hospitals, and that's now Intermountain, and we also have Healthcare Partners Nevada, which all happened in the past basically year and a half. I always joke that our ex-CEO, Dr. Mark Harrison, is a great guy, very progressive, and I think he gets bored, so he's like, you know what we could do. And so now we have 3 regions, and now we're still trying to figure out how to get not only our facilities, but also the outreach. And so we're now broken down into 3 regions right now. But this was the core right here in the middle, this Canyons region, which is what we set up all of our coverage for. So I'm going to cut through this a little fast, but give you that 10,000 foot view. So we have like 220 plus clinics, 24 hospitals just in the Intermountain facilities in that central region, because all this merging is all recent. But I just wanted to let you know that. And then, we just picked up SCL Health, which is now Intermountain, which is in Colorado, Montana, and Kansas, and it's adding this. But they have their own staff. It's just that they don't have maybe a robust telehealth, and so we're going to help them with some of their needs and expand because we have more resources. I love this slide for the fact that we started in 2013 with our core programs of telecritical care, crisis, stroke, newborn critical care, and those, and the big 4 were really right here: newborn, tele, stroke, crisis care, and telecritical care. And it took 7 years, I think I put it on there, 7 years to get to 1 million visits, and nothing like having a pandemic, right, to accelerate to get to 2 million in 6 months, and now we're at 4 million within 2 years. And again, not rocket science, and you guys probably have a similar experience, but we have now 1,300 access points, meaning 1,300 cameras or carts or in-room cameras throughout the whole region that we now have doing tele. You don't need to know too much about this, but we did create a command center, essentially like we're not allowed to use the term care traffic control, because I think that's been registered trademark, but it basically is like a
trademark.
Yeah, like an air traffic control center, right? But basically we have Intermountain Telehealth that falls under, clinical services, and within Intermountain, this entire Intermountain Telehealth, we have 2 things, because we had Connect Care for a long time, which is just basically, patient can get on anytime, like the kid has a rash, and go right to an immediate visit. We keep separate. It's still part of telehealth, but it's kind of separate because of it's so robust. And that's expanded to doing e-visits for patients who even want to leave, messages for their specialist provider. So that's kind of really our focus right here for the provider, right? All acute and specialty consults, teleendo, teleroom, teleID, tele. Okay, this is actually our command center. A little bit morphing of the pictures. This is Dave Guidry. He's our telecritical care doc, and I always joke, man, you guys really rate, because you get like 6 monitors at least, and sometimes they even have a laptop over here. But this is where all of our staff do like remote patient safety monitoring, at home, and also at rural sites where they don't have enough nursing staff, but we will have folks monitoring, say, high-risk patient for falls, et cetera, and then we can alert the staff there that something's going on in a patient's room and talk to the patient, sir, please get back in bed, et cetera. But there's a lot of that going on in addition to actual teleconsultation. Now, they just happen to be on site because they have a lot of resources, because they have an APP who does telecritical care, and also they have some other resources for funneling and triaging. And this is also our patient transfer center, placement and transfer center. So it's kind of like a one-stop shopping. And if you were to go left down here, you would find the telehospitalist in the corner, coordinating all their telehospice work. But you can imagine how convenient this is for me to just get on the phone with telecritical care and kind of have at it these are all the devices. If we're talking about just big picture, I kind of joke about one thing. This screen up here is really for tracking all patients through the system. And it looks like this. It's kind of like a departure and arrival at the airport. But I was coming home one night when we first set up this virtual care center, and I always joke with them, it's an actual physical building, so you probably can't call it a virtual center, but nonetheless, they're providing virtual care. However, I could see into the virtual care center on my drive from downtown. We just come from a concert downtown, and I could see PHI on this right here through the windows from the freeway. So we fixed that. Had to change the tinting in the windows and all that stuff. But bottom line, these are the tools we use. And, as you guys may well know, COVID just accelerated all this remote patient monitoring. Both ED was putting COVID patients back in their house if they met certain criteria, and we would do the remote patient monitoring from our virtual care center. And also the nice thing is we could leave the ED attendings on as a point of contact so that then if something got worse, they could go right back to that same ED and just be, fast tracked into the hospital. So a lot of stuff that, again, acceleration, right? Change, but there's a lot of good that came out, a lot of bad from the pandemic, obviously, but a lot of good too. We like having the in-room cameras. I don't have, but it looks like an upside down R2D2 unit, very high resolution. But, because we have a lot of outreach facilities, we don't put in-room cameras. We just use a cart for mobile. This is example. Oh, go ahead.
Yeah, just a quick question though. We have a lot of residents and trainees and medical students, watching with us, your presentation. And I just like to, ask you, how many hospitalists or telehospitalists and how many tele ICU or, infectious disease specialists using telemedicine, just to explain, that this is a changing, as you mentioned, changing, phase of medicine, doing more virtual care and doing more telemedicine. Because in the future, Sue Lee here will be probably a resident and become an attending, what is the job market for all these virtual care specialists?
Job market is wide open. I will say this, we have difficulty funding our infectious disease in-person positions that are actually funded, budgeted spots, but I was able to bring on 2 ID docs and a new pharmacist, a second ID pharmacist, and now 2 more part-time ID docs, and after that 3 more part-time ID docs for tele that I'm actually now going to bring on from, say, the East Coast, and they're just going to work for us from the East Coast on our system. And I use that as an example. This all happened in the last couple of months because there's so much need through so many regions for telemedicine that we're able to fund through telemedicine and budgeting for telemedicine right now better than we are for inpatient in-person work. And why that becomes an issue is because now what's happening is we're starting to look at doing more telemedicine even for our traditionally in-person facilities, because that's our only way to get staffing. It's not I'm not saying everyone has this problem. For me, for tele, it's a good problem to have, except there's constant addition of outreach sites. And if we start also covering places where we can't staff in person, that becomes a challenge. For the telehospitalist piece, right now they only have 1 person on, but they have an APP with them. Telecare care, they have 1 person on per shift, they have an APP, but they're probably covering 40 facilities.
Wow.
Now the thing there is not everybody's, got an ICU patient, et cetera. But the nice thing is it's already part of the process where when you come in, that you can get tele visits from afar in one of our small community hospitals. So they just jump on. It's specialist medicine for tele is different. Telehospitals and telecritical care are running the show. So let's say you've got a small community hospital that has, these poor guys, they have like a 10-bed hospital, and the guy who's their family medicine doc, who's also the hospitalist, who's also running probably the CMO, and they can't admit every single patient if they happen to get, say, 2 or 3 admissions a night. That's where a remote telehospitalist will get called by the ED staff of that small hospital and tuck that patient in overnight, so that provider in, say, very small town doesn't have to be, has already been up, right, all night delivering babies, and now we're running ICU, quote ICU. These are basically not the ICU that you guys are used to in, say, a major medical center. So that's kind of the role of the telehospice, is to be a safety net to get them tucked in, put the orders, talk to the nursing staff, and then the next morning, that way the person who's on there as a hospitalist can actually take over. But remember, these guys are working as, they work as hospitalists in these small community hospitals. And by the way, definition for small community hospitals typically accepted as 200 beds or fewer. But even that, you can have a 150 bed hospital that has lots of resources, or a 200 bed hospital that doesn't have a lot of resources. And it just depends. Like I said, each place is different. So if they need hospitalist coverage at night, we can, cover down on a couple of admissions to kind of give relief to their docs, and really adding on the APP piece, who works like tethered, tied at the hip with the doc right there. That really works well because they can run their cases automatically. And so, like, if it's not saying that every case is a chip shot, but if it's a chip shot of like, oh, routine admission, for pneumonia, and put them on these antibiotics and they feel really comfortable and they get good training, they'll do that. And they might just run it by them, later in the shift. But lots of job opportunities, I will tell you. And staffing wise, we all say that tele is just a tool, right? You can do ID in person, ID phone call, ID e-consult, ID by camera, and it's all a tool. But because it's so robust, it really does require its own structure for staffing, logistics, operations, and that's a challenge. And staffing models throughout the country are still being developed. And I will tell you, I get lots of calls from people say, hey, tell me how to staff a tele program. And I'm like, well, this is what we did. I don't know if it's going to work for you, but we did come up with some numbers based on what services we were providing, and every place is going to be different. So, if you guys crack the case on a good model, that's something you can share with the country, because I get asked all the time to share, how do we staff? And, then people figure out, well, we'll just start and then we'll add. It really just depends on how fast you grow and what kind of services you offer. So I'm just going to keep going. I don't need to go through all the slides, but I do want to get you to kind of understand, our emphasis for selling this, if you will. It's not for money, but like to the executive committees of each small community hospital, because those of you who are in ID and doing stewardship, you can sometimes go in and people don't know what they don't know, right? Mm-hmm. The whole point is even though there was a national action plan by the executive office, right, the White House, I think it was President Obama at the time, in 2014, and then there were Joint Commission standards and CDC guidance and all that. There are places that are not doing stewardship, even though it's a requirement. And you also have to remember, everyone thinks in big hospitals, Joint Commission. There's so many small community hospitals don't do Joint Commission surveys, but they have requirements for CMS and for funding. And if they don't have their stewardship piece down, then that's where they can have regulatory authority issues. And that's where we target the leadership to say, hey, look, I don't know if you're aware of this, but these are the requirements, for your state funding, your CMS, et cetera. So that's kind of how we approach the stewardship, so they can understand, what they need. But their pharmacists are the ones who are really, sort of salivating at getting some help with ID, tele, stewardship pharmacists. And we just offer, this is the part that I think will help with that 10,000 foot question. I'm going to go pop them all on there and go, these are our 4 components of ID tele. We have a 24/7 line that's been going since October 2016. And then after that discussion happens between, say, a small community hospital provider and the ID doc, then we can decide, okay, sounds like we should put the camera on, or, oh, hey, I'll just pop in an e-consult. Or it might be, we're done because I agree with what you said, and just change the dose of your amoxicillin from 500 milligrams to 1 gram TID for, a better pharmacodynamic effect. And so you can end up with no documentation, e-consult documentation, asynchronous, as the surgeon individual, sorry, forgot the name, asked before, or full-on telemedicine consultation, which is the same as basically doing a full consult, just happens to be by camera. So that's the consultant piece. And we've expanded now to have outpatient video visits, even for our remote folks, because we realized we started with inpatient. And if you have inpatient and you think, oh, that's good, we'll take care of all these guys. And then they go, hey, who's going to follow this endocarditis guy in my small town, once they get out of the hospital? And you're like, oh, it's a good question. I would normally see him in person if I was doing in-person consult in my medical center. Why can't we do the other thing? Well, it's called staffing. So we would help guide the primary care docs, but as we expanded staff, we were able to do more remote follow-up by outpatient. And then the second part of the tele program, which is the integrated piece of stewardship, is the day-to-day, and also the longitudinal program development. And so I have myself and my tele-pharmacist lead, we serve as members of the stewardship teams for all of our 17 small community hospitals, but it's their team. We don't take over. And this is that part about like, you can fish for others. And I have good friends, for some of you who know Javid Siddiqui, who did the, he's going to kill me if I didn't remember the name of his company, but he's been doing telemedicine for a long time in California. And he will basically, I say, he fishes for people. He'll go in and do their stewardship, and he's their stewardship guy. What I don't like about that model, it works for them, is that if I'm a chief medical officer, which I have been, and Joint Commission or CMS comes to my facility and they go, so how do you guys do this stewardship thing? And you go, oh, that guy does it. I don't like that. I feel our staff, it's a requirement for each hospital to have a stewardship program, not have someone do stewardship for them unless it's integrated and they're included. And I'm not trying to make it black and white, but that's why we don't go with like, we'll just do it for you. We offer different forms of stewardship contracts for outreach sites to say, would you like office hours once a week? Would you like, daily surveillance sessions? Would you like us just to give you guidance and training? And we do offer online training for them too. So my point there is the same as earlier, is that every place is different. Some do extremely well, and they just need some guidance once in a while, and you do like a monthly visit with them. So all comers, it looks like it takes all shapes. And so this is kind of just showing you that if I got called on a streptococcus bacteremia, and it's a flat red leg cellulitis in a diabetic patient with a group C strep and had bacteremia, and we did a quick check. This was early on. And honestly, I'll tell you the reasons why you turn on the camera nowadays might be to clarify with the patient. Like we had a Norwegian skier come off the Park City ski slopes and said, hey, he's got the flu and he's not getting better. And then we just turned the camera on, looked at him, talked to him. And then within 5 minutes found out, oh, you were in West Africa last month. He had malaria in January, treated as the flu, but he had thrombocytopenia and anemia, et cetera. So, that's why we might turn the camera. But if I have a really solid hospitalist and I know them well, and they say, Todd, I got this group C strep bacteremia and it's a red leg cellulitis, it's non-purulent, and do you think this antibiotic's good? I might not turn the camera on, especially if I have 20 other consults for the day. Okay, and the last piece is we do an echo once a month for, we've been doing it even before we changed it to the echo name. We started off as education and antimicrobial stewardship and ID exchange, easy, and now it's an echo. I always say, oh, because they gave us t-shirts and we had to put the echo button on there. I think I actually have an echo. Nope, I took it down. Oh, Dr. Aurora would be really upset at me. Okay, here's our current locations to give you a flavor of what we're covering. The red sites are all the small community hospitals in our system. So we cover 760 beds, but don't get too alarmed about 760, right? 760 at, Texas Tech School of Medicine or primary teaching hospital are different cases than these 760, right? You're not going to see a renal transplant guy, who's got PTLD at a 13-bed hospital, because that guy is going to be gone before they even call us. Or we might be the ones telling them they should be moving, but they're different patients, but they do keep you busy, as you can imagine. And that's why you'll see the variety in telemedicine, sync versus async, or phone advice. And honestly, a lot of it comes down to the comfort and confidence level and of that provider, and also your comfort and confidence level of that provider based on that discussion. And so we don't make a blanket rule, and we certainly don't decide. If they say, Todd, can you take a look at this guy? We're going to take a look at that guy. We're not going to say, I don't need to take a look at that guy, because that's what they need, right? They're asking us for help. Okay. So all the reds are our small community hospitals. The yellows are our major medical centers. Those have on-site ID docs. And our tele docs also rotate for those of you who are graduating or curious about, like, I don't want to do 100% tele. We still rotate on for in-person and do teaching rounds on the inpatient consult service, et cetera. And then now what's happened in the past few years is we've gotten outreach sites in the green that are just kind of expanding. And like I shown earlier, we're starting to expand into these other areas. Again, no interest in Texas. Not as a negative thing about Texas. I was in San Antonio for my training at Brooke Army Medical Center. And I should just put something out blasphemous. 2 of my children went to, thank God, virtual, you can't throw something at me, Texas A&M. Whoop. So there you go. Don't you guys do this and they do this? All right, now I can just feel the ire. Okay, this really is the one-stop shop for what happens. Someone that has an issue at a local hospital. Pharmacists are doing their daily surveillance that we've trained them to do on stewardship using a Vigilance software, and they're getting the big things. But a safety net is our ID tele pharmacist at the mothership over here, the beautiful mountains, the small community hospital, is actually looking at the high risk alerts like bacteremia, multi-drug resistant organisms. I'm going to pause for a second because I've had some internet issues. Are folks still hearing me?
We're hearing you, sir.
Good. And I didn't mean to make that weird, but we've had a windstorm and some things went out, so I'm on a hotspot. Okay. So, they're catching this stuff up front, and we want them to talk to their providers, right? This is the whole, at every hospital in the United States, it's a requirement for doing stewardship. But you can imagine this can be challenging. Sometimes they want big brother, like bad cop, to come in, et cetera. And we're happy to do that. But our pharmacist looks at the multi-drug resistant and the high cost pharmacy, like if someone's on, say, Marrow and Dapto, et cetera. And those of you who have done stewardship, that at an 8-bed hospital, if you have one patient on a broad spectrum antibiotic for like even 4 days, you can ruin your, antibiotic use per 1,000 days instantaneously. And, God forbid you have somebody on, say, Dapto and ertapenem for a month, that can just make, shoot it through the roof. The nice thing is we get this collaborative review, even though they're awesome and they're worth their weight in gold, the whole like, gosh, you found another one. It does kind of add work. And about 40% of our surveillance efforts have led to a consult generation in the form of asking the provider, hey, do you want us to be involved in this case? And I'll give, some of the harsh examples. You got a MRSA bacteremia patient and the PO vancomycin probably isn't going to work. So maybe you want us to be involved in the consultation. Yes, please, Todd, come on the case, that kind of thing. But I love this right here. I think this is so important. That was that picture earlier. And then we go right at the provider at the same time. So we never push onto a case. We only come onto a case if they say, hey, we want you to be involved. The pushing comes from here, which is surveillance for stewardship, that they then say, hey, maybe you should change the vanc to penicillin, et cetera. So here is they're fishing for themselves. Here is we're teaching people to fish. And then sometimes, hey, maybe we'll help them reel in this bigger fish because maybe it's too much for their boat. That's maybe a rowboat. Okay. The workflow, I already showed you that case. So basically we got that patient on a MOX PO and they were on vanc, cefepime, metronidazole when we got called, and we got them on a MOX PO like within 24 hours. And that was that. So you can see the benefit. I'm going to highlight this as another 10,000 foot view. What do you start with? And I don't mean to be insulting. You guys probably have all metrics, et cetera, especially if you have an whole institute on rural and community health, which we didn't have. So this was like I call it the John and Todd, like, let's just count stuff in the beginning, which we did. And then we published that and said, here's what we counted. John has a full beard you saw in his picture, so that's probably John. And that's what we did. And believe it or not, even that wasn't easy. Like, how do you show how many phone calls you get? Well, I developed a red cap thing that takes 12 seconds to enter. And like 50% of my ID docs wouldn't take the time to enter that they got a phone call on the weekend and that it was, bacteremia. So I changed it to have it all go through the patient transfer center and have them log it while they also enter a FIN identification number so that if we do a consult, it's already in there. And that turned out to be, victory, because now the physicians are like, oh, great, I don't have to log this red cap. But then you start seeing that. I'll show you this. The key was creating the right templates. We have Cerner. It's
Cerner,
actually different version. What do you guys have?
We have both Cerner and Epic.
Yeah, Epic works better for some of the tele stuff, especially if you guys are part of that core project for e-consults. Cerner, not as great, but if you get your Cerner folks involved in we call it DTS, but your IT folks for tele, they can actually, like I specifically said, if I put in this type over here, the specific type, and you see this, I can have our data folks count those. And then on there, it says how much time. So we were able to take all that and also make it so that I made their problem list. I changed the title to infectious disease diagnosis, and we just keep the infectious disease conditions on there so that we can track that too. And then we still track all these in form of text, sort of a text search function. And then we also have, the standard, all that stuff that everyone has to do, attestation. And the red cap, what's that?
Those were smart texts. Smart text.
Well,
yep.
Right. And so honestly, that's not the best way to do it. But the nice thing is we have some options now because, we weren't coding for e-consults because it really doesn't meet criteria. You have to have a formal consent with certain things, et cetera. And it can't be 14 days prior and 14 days after that your service has seen them. But we have now what's called a no charge e-consult code. And I told all my guys, put in every e-consult you do as a no charge e-consult code so that someone else in medical group can track that for, RVU productivity. So we did track a lot of this, and I'll just kind of jump because we got some time issues, but we tracked all this on a red cap initially, and we also tracked how many reviews and interventions our pharmacists did so that we would know, this is my, if you build it, they will not only come, they will want follow-up visits, which we didn't really realize early on. And so we found that a lot of these were generating this, or they got so comfortable, it's like, hey, can you see this guy? Well, we had to build out staff. And I'll tell you what was, I hate to say this, and I wouldn't say this on CNN. The blessing of the pandemic was I had started to implement telemedicine outpatient by setting up clinics at our biggest small community hospitals so we could do follow-up of those more complicated cases, which is a chore in itself. Well, now when video visits, went full bore, thank goodness for that, because it's not smart, in my opinion, to set up outpatient telemedicine, except in unique circumstances. Like say in the community, the patients don't have bandwidth. Then they can go to the clinic that they go to, and then you could see the clinic patient in internal medicine or general surgery. If you time it really well, you have a nice multidisciplinary visit. But honestly, the video visits is better because you don't have to use their staff to get the patient in instead. You just go straight to video visit and you get your follow-up that way. And I certainly condone that. I had set up one clinic and that was enough work. And then the pandemic came and I was like, yeah, we're going video visit. So that helped a lot. But if you got a pharmacist, they will generate work. That's another thing that'll happen. This is one thing I want to show that we tracked, just to show one thing. You mentioned earlier about sync, async, phone calls. We tracked all of that. And if you look in 2017, look at the yellow for two-way, that's a camera, and e-consults, which are here, a lot more camera visits. We have fewer sites, we had more time. Next thing you know, it's still going, but now look what's happening in 2019. And if I showed you more recent, it would be e-consults up here and telemedicine visits down here. Part of that was the small community hospitalists got better and comfortable. And I'll give you an example. I got one guy, great guy. You make these great relationships. You keep lots of cell phones, right? And when they call you the first year, they say, hey, I got this guy with Staph aureus bacteremia. What do I do? And then you have lots to do. And then you get a call the next year and they go, hey, Todd, I got this guy with Staph aureus bacteremia. I have gotten follow-up cultures. I got a transthoracic echo. I actually imaged his back because he had some back pain. I was looking for, discitis, osteomyelitis. And I've switched him from Vanc to Cefazolin because it's MSSA. And you're like, all in 1 year, that's different. I may not turn on the camera on that case because I feel very comfortable that he knows what he's doing because of the mentoring that went on for a year. People who use PO vancomycin for Staph aureus bacteremia and realize real quickly when they started consulting us, like, yeah, you can't do that. But that's the kind of stuff that affects your ratio. And then you could plan for staffing, right? Because we looked at our times, and I'm gonna go back here to say, our camera time was early on. This is the first 18 months ID a couple years ago, and phone time was averaging 8 minutes. Those numbers have come down significantly. Honestly, I don't have the time to go back and look at what they are now, but I will tell you that e-consult time is even lower than 19 minutes. And the numbers, like I told you, would be through the roof here. But in the first 18 months, we had 1/3, 1/3, 1/3. Phone advice only, telemedicine camera only, or e-consult. And that was first visit, because you could always go to an e-consult as a second visit. But first visit, actually, no, these are the only mutually exclusive. So, but more importantly, they were generating from stewardship reviews work. And then 32% of our work on telemedicine in person was resulting in an in-person follow-up for our local hospitals that were within, say, 40, 30 miles. And since then, it's gone up and we've covered remotely. We always joke, you're going to need a bigger tele service because work begets work. Everything you do, once you build it, they will come. And that's the key. This is a summary slide of, this is actually their stewardship committee at a small hospital, like a 20 beds critical access hospital. I should ask anyone to guess who the doc is. Actually doesn't show as well. So in our first meeting in person, actually became really good friends, but he literally said in our first meeting in person that he considers ID pharmacists to be the devil in front of my ID pharmacist. So we had to win him over, and we did. And they really great group. You can see where the telepresence comes in, and it's their team, and we're just there to help teach fish. So we established these, and we let them do the education, training, and mentorship. We do that on an ongoing basis, and they all participate in the ECHO program every month. I'm not going to go into the dirty details because I kind of highlighted that lots of stuff to do, lots of work to be done, but you got to track it. You got to show it, and you got to show the value of decreasing antibiotics. And we use sort of the same NHSN surveys for antibiotic use, and we do the large, medium, small comparisons so that when you go and show the Storcher team at one place, we joke here that this one, San Pete and Fillmore and one of these other ones are all in the same area, and they're right by Delta. And they all want to know every time you go to their meetings or talk to their leadership, hey, did we beat Delta? Did we beat Delta? And I have to say, well, actually, you did beat Delta, because that's the name of the hospital. They just want to beat Delta. I'm like, well, you got some other stuff to work on, but you did beat Delta. So I don't know why that is. It's like a local geographic rivalry, which becomes a joke now because we always walk in and lead off with our answers like, you beat Delta, everybody rest assured. Now let's talk about what you should be doing. And then we focused on Delta to see how we can get them down. They had an attached long-term care facility, and their antibiotic use was being unfortunately raised by some of that, like, one patient on ertapenem, I always say. I already commented about this external concept. I want to jump to a couple of things that show a benefit and then wrap up so I can get you guys out of here. But it really comes down to what they want and need. They may have some good stuff, and you only have to do some guidance on certain things, and you're just going to have to, figure out what's the best thing that's going to work for them, the model. And I always say we put it like a Chinese menu where like they just want, one thing from column A and one thing from column B, but nothing from column C. Like they may not want, every single PACE review or assistance with review, but they'll summarize it and say at the end of the week or something like that. It depends on the pharmacist on site. And don't forget, it's not all Joint Commission. Okay, I've already said that one. You've only seen one. I'm not gonna highlight this. Suffice it to say, you gotta track the data, do the ticking. And so we started with just showing descriptive epi of this is how many consults you get, et cetera. This is how many phone calls to show the workload and show how much time it is so we could get the staffing if we needed it, which did work. Then we showed some actual antibiotic decrease use from teaching them how to do chart reviews and showing them it may not just be the amount you use, it may be the fact that like you may have higher usage, but all of them were appropriate because you had a bunch of ESBLs, resistant organisms. So I'm going to cut through some of these just to go to one. I think there's a slide. This is the one I'm going to stop with. To me, this is a big success. We just submitted this one everyone saw that there was like large antibiotic use in COVID because people are like, this is bad pneumonia, let's put them on vancomycin, azithro, blah, blah, blah. And then come to find out that, even the procalcitonin and a lot of other variables that might be from bacterial will be elevated during severe SARS or COVID-19, right? So we actually decided at all our facilities, we were going to put from 11 to 12:30. The other thing was, you guys remember this, if you didn't look at CNN or whatever your choice is for, or look online every hour, you forgot the fact that now the medicine you were using an hour ago doesn't work. It felt like that at times, right? Well, can you imagine like an 8-bed hospital, 20-bed hospital guy who's delivering babies and seeing family practice clinic and running the soccer team for his kid probably at the same time in a small area? They can't keep up with that. That was our job. So we just set these COVID rounds, and we had our DTS guys create a COVID hyperinflammatory syndrome, the CHIS criteria on one page. So on every patient, we could pull up their CT, pull up their CHIS, and I have my 2 fellows, my 2 pharmacists, I'd have the critical care doc and the hospitalist, and they'd come on and they'd run the cases that they had questions about. And I will tell you, within a couple of weeks, they stopped running cases, but they would sit on the cases on the session for telecovid rounds to listen to what the other people and other sites were having to learn more about, you went to monoclonal antibody. He got remdesivir for 10 days. He got dexamethasone, but he didn't. Bottom line, it was real-time decision-making, and it took the place of consultation. And we would write a note for like electronic consult equivalent note to reflect the continuity, but not for charge, because they do a charge through the system in our facility. So I just had to put that one piece in there, and I think I'm going to stop because I just went over. But I'm happy to stay on for questions. I know people might have to go because of my inability to figure out Central versus Mountain Standard Time.
No worries, Dr. Vento. Thank you very much, by the way, for the excellent presentation. I learned a lot, from this presentation. And we have a infectious disease specialist in the audience as well. Dr. Shrestha, our infectious disease specialist at Covenant Medical Center, is here with us. And I would just like to ask Dr. Vento, with your telemedicine activities, was it prove to decrease your antibiotic utilization and also make a improvement in your antibiotic resistance in your area?
Yeah. Oh, you're asking, were we able to? We were
Yes, sir.
able.
Yeah.
We definitely were able to show. I have to show one picture at the end too, just for the whole, like, we got too big for our britches and they actually started letting us use the life flight plane instead of us driving everywhere, realizing that we could be more effective. So I just have to put that out there because, you know, you grow and grow and grow. You got to like come up with some other ways to do things. Bottom line, yes, absolutely on the antibiotic use. Very easy too. You know, like I said, if you got like, if every patient gets vancomycin hitting the door, and the MRSA rate in Utah is not high. And, you know, I trained in like the DC area and worked in Houston area and, you know, LA, and, you know, that's like MRSA, you're covering a lot of MRSA, but our MRSA rate was low. We were using a lot of vancomycin. So that alone, we could get that down by having people understand risk factors for MRSA, but also their use of, say, vancomycin up front for sepsis when, you know, there's a lot of genital urinary infections that were becoming like secondary bacteremias or complicated UTIs. And, you know, patient hadn't had hospital exposure, you know, they're still fine with ceftriaxone with a high rate of success. You know, it's not like everybody gets like cefepime, vanc, and Flagyl or Dapto, you know, cefepime, et cetera. So answer is, yeah, we showed a lot of decrease in antibiotic use. Haven't shown the follow-on decrease in resistance per se, because that's sort of I think a longer tail.
All right. Well, any question from the audience or the crowd?
And
If
I'm happy
none-
to share slides as well, because there are some things about other things you can think of and some resource slides, because I sort of skipped it, but I am very happy to share slides with whomever. I can give to Laura or whomever, if that helps folks. And also I'm happy to provide my cell phone if ID Tele folks want to reach out and share ideas, and I can share how we staffed it and give you a staffing model if that helps your purposes.
I'm not quite sure if Dr. Chemitiganti had a question. Dr. C, you could unmute yourself, sir.
Oh yeah, let me look at this. Oh, good question. Okay, so we have our dedicated credentialing and privileging resources in Tele so that they can focus on that. And they do have to be licensed right now in every state. Now, there's a lot of regional compacts that are coming out. I think one's called like the ILMCC or IMLCC. And so they're supposed to make it easier where all the states can actually work together. But when it comes down to it right now, you're still getting to the individual state. I just, for example, had to go back and forth with Arizona to renew. And honestly, the only thing I did was put a signature in and confirm that these answers were no. And then my telecredentialist actually did all that. So that's the licensing. You still have to be licensed in the state where the patient is. And you can see that gets tricky. I'm a VA patient, actually, right? And every time I get on the VA, it says, where are you physically located right now? Like, it makes me answer. I'm like, I could lie and tell them I'm not in the Bahamas, which I'm not. But like, nonetheless, like, those are issues, but you have to be licensed in the state where the patient is technically calling for. Billing for e-consults is tricky. Billing for phone, we don't do it. It's just part of the service. Oh, the reason why our outreach or external piece works is we do a subscription. So if they say, here's how it works. Small hospital comes to us and says, hey, we want some ID consultation. We want to get access to that phone line. And we want to have like a couple consults a month because we don't have a lot of stuff going on, but our guys want to have somebody to talk to and review and give a e-consult or a full consult. That's just a subscription. I don't have anything to do with that. My operations folks say, oh, that'll cost you whatever $1,000 a year to get 100 consults a month or a year and access to the on-site. They all want access to the doc 24/7. The good thing is they don't typically call, knock on wood, 2 in the morning, 3 in the morning. But it is there, like if they get their meningitis case. So we don't charge for that because it's part of the overall subscription that we have them pay to have the service, depending on what service they want. Now, they can decide, do they bill for things on the end, and we leave it up to them. There are some opportunities for that. On the e-consults, very difficult. E-consult requirement for outpatient, inpatient, identical. You cannot have seen them as a service 14 days prior and 14 days after. You can put the e-consult in, but if you see them like in person or on camera, like 7 days later or 12 days later, then it voids the e-consult that you put in a charge for. The charge for the 99451 run-of-the-mill e-consult is really, it's a 0.7 RVU, and it's like a $65 charge. And insurance, most insurance companies do cover it, but they cover like $35. And I'm not trying to give you a bunch of numbers. Bottom line, it has been a challenge, and that's also been a challenge. I sit on the Telehealth and Emerging Technologies group for IDSA, and same thing all around. UPMC's done this really well. Rima Abdelmasi has actually put in her own sort of corporation to do this. for UPMC, even though it's part of UPMC, and she can't figure out how to get the e-consults right, because once you do an e-consult, the minute you do something else, it's done. And they have to be consented on a two-component consent, which it says the patient's been told by their hospitalist or their outpatient doc, hey, I'm going to get a consultant who's going to write in your chart and give us some recommendations, and you will get a charge. That has to be told to them according to CMS. So you've got to make sure all that's in play. And you can imagine there's a lot of coordination there. And then telemedicine visits are billed exactly the same. We didn't start billing for telemedicine when we first started because it was a service we offered only to our services and our hospitals, and we just didn't bill. They got like a larger facility charge through our network, but we didn't bill. Now we're billing individually as if the ID doc was there doing the consult. And on the outreach, we don't bill individually because of that contract subscription for the year, but they can actually figure out, since we also have to be privileged at those sites. That's the beyond licensing issue, which can be its own issue. If you're going to be writing in their chart, then you should have tele privileges to be doing that. And giving advice over the phone comes into play too, because if they write Dr. Vento, blah, 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 it's nice that Dr. Vento is privileged at that facility and access to their EMR and all that. So a lot of those things. But again, anybody wants to talk like that, I can set up a meeting and we can discuss that stuff too.
Thank you.
Yeah, absolutely.
Yeah, thank you, Dr. Chemitiganti, for that. By the way, don't forget to do your session evaluation to get your CME credits. And next slide, would like to thank Dr. Vento for your time. And we would like to, give you this Texas Tech TexLa Challenge coin. We'll be sending you by email. Thank you very much for your service and for being a champion of telemedicine.